Most medical billing is simple. One service, one flat price. You bill it, and you're done. But anesthesia is the line that won't sit still. It requires a moving mathematical calculation for every single case. Long-term accuracy starts with a clear division. Standard mathematical rules stay in the main workflow, while complex medical exceptions are isolated for separate handling. This initial calculation works like a taximeter. There is a base amount just for starting the ride and a running timer for how long it takes. For now, we are deliberately ignoring the money. We start strictly with units. The first variable is the base unit, a preset difficulty score for the procedure. This score is tied exclusively to a distinct anesthesia code, usually starting with 0. It completely rejects the surgeon's code. Next comes the time unit. This is the running timer, and it's longer than the surgery itself. The clock starts with patient prep and only stops upon a safe handoff in recovery. That entire window is billable anesthesia time. To turn that clock into units, there is a rigid mathematical rule. Take the raw minutes and divide by 15. 60 minutes equals 4 units. 90 minutes equals 6. The output is purely numerical, perfectly slotting in next to the base units. By isolating this two-part baseline, base units plus time units, you stabilize the most volatile piece of the billing process. You now have a solid mathematical foundation to build on. With the baseline locked, the case takes a short trip. Every calculation passes through 3 sequential checkpoints to account for the specific realities of the surgery. Checkpoints 1 and 2 assess the patient. If the patient has a severe disease or a true emergency, these checkpoints drop extra units right on top of the baseline. Healthy patients pass through without adding anything. Checkpoint 3 doesn't add units. Instead, it places a physical flag on the final total to track exactly who performed the work, whether it was a single doctor, a nurse anesthetist, or a doctor directing nurses across multiple rooms. The conversion factor is the final variable. This is the singular mechanism that assigns a dollar value to a unit, calculating the final dollar amount based on the total units accrued. If the checkpoint flag indicates a doctor was directing a nurse, the dollar amount is split exactly down the middle. Half goes to the doctor, half to the nurse, ensuring the payer isn't billed twice for the same minutes. This sequence, counting units first and introducing money only at the end, finishes the mathematical portion of a standard case. Real-world medical anomalies are always handled entirely separately, one card at a time, to avoid complicating the baseline math. Medicare generally refuses to pay the extra units for patient health or special situations. To accommodate this, an overriding rule overlays the equation, zeroing out those extra units for Medicare claims without breaking the underlying formula. If a patient has 2 distinct surgeries under one continuous stretch of anesthesia, you do not add the base scores together. The rule forces the system to retain only the highest base score, while the smaller one fades away. Some specific cases, like flat-fee cane injections or unique obstetric codes, route entirely around the core math. They operate on their own track, never touching the unit calculation. These specific rule sets capture the messy real-world variables without rewriting the standard logic. Moving these rules into a digital space is a direct translation. A software fee schedule is simply the mathematical blueprint applied specifically to each payer and plan. There is a significant revenue trap in the setup. Payers pay the lower of your billed charge or their set allowed amount. If you set a charge that dips beneath that threshold, you permanently cap your own revenue for that service. To prevent that, you follow a strict sequence before the system goes live. Build the schedules, price them, set the effective dates, and test every mathematical pattern for accuracy. When daily cases start flowing in, data entry requires discipline. You capture the raw minutes directly from the anesthesia record. By preserving the source data, you keep the ability to rework a claim if a payer audits the time. Next is the confirmation of the insurance source. Pulling insurance from an appointment record versus a standalone patient profile can trigger entirely different fee schedules. You must ensure the software pulls from the correct origin. The operational cycle is only complete when calculated charges are systematically reconciled against actual payments and denials. The money must match the math. Most financial failures in this space aren't the result of one massive mistake. A failure to sequence these steps correctly creates a compounding loop of small, repetitive errors that result in significant revenue leaks. Flawless anesthesia billing relies on 3 foundational variables: the code, the math, and the modifiers. staying in sync from the first minute to the final dollar. Keep them aligned, and the calculation takes care of itself.